My name is Dr. Edward Ngwenya, and we will be continuing with our plastics podcasts. Today, we'll be talking about cleft lips and cleft palates. Now, this is a huge topic, so this will just try to be a high-level presentation. And the assumption, as I always say, is this does not aim to replace your learning, but to augment your learning. So, just to pick up a few points that we should be able to know. I think the most essential thing in knowing any pathology is knowing what the normal is. And in relations to cleft lips and palates, what's most important, most imperative, paramount to know for you is the embryology. You must know the embryology of normal formation of cleft lips and cleft palates. And just at a high level, generally, this all begins between the 4th to the 5th week of intrauterine life, where we have these 5 prominences. We've got the frontonasal prominence that comes from the primitive forebrain, and we've got the maxillary prominence, or rather process, and the mandibular process, which come, or rather derived from the first brachial arch. So what generally happens, and it would be great to just look at some schematic views. If you could get hold of a video, excellent for you to do, so you can see where they lie and where in relation to the stomodium, which will be the mouth opening, and generally they lie around there. And so you have this frontonasal prominence that then comes down and has these 2 bilateral thickenings on the surface of the ectoderm, and these are generally located in the inferior lateral aspect of the frontonasal process, and these we call the nasal placodes. Now, from the nasal placodes, you would see that on both sides of these nasal placodes, they further start to thicken, and then you would then get a thickening on the right or on the medial aspect, and the thickening on the lateral aspect, leaving then this hole in the middle known as the nasal pit. So the thickening on the medial side is the medial nasal prominence, and on the lateral side it will be the lateral nasal prominence. And these structures, as the development goes, they come together and then fuse in the midline. So the medial nasal prominence will be eventually what we will know as the nasal tip, the philtrum, the premaxilla, and the cupid's bone. Those are the structures that would then come from that. And the nasal pit, of course, would be the airway as we enter. Then the lateral nasal prominence would then mark the nasal alar. So this generally, excuse me, this generally is what will happen. As this is happening, so also it's happening in the maxillary process. Now, they then come together and fuse, and these, the maxillary process would what becomes the lateral lip elements. And of course, the mandibular process being the lower lip, then coming together there and also fusing. Remember, they are derived from the first brachial arch. So if they come from the first brachial arch, what you then find around the 7th week of intrauterine life, there will be this myogenic mesenchyme that comes from the 6th somite. It then migrates into these lip structures, accompanied by the facial nerve, and that's what will then assist in our musculature as we know it, the orbicularis oris muscle, and the facial nerve, which pulls then with it as the supply therein. Now also, there will be a process known as palatogenesis. Now, this we've defined the cleft lip. So we also know that if we've got problems with these processes fusing, there's going to be a gap. There's going to be a cleft. So these will form your cleft lip. Now, this may happen unilaterally on one side, it may happen bilaterally on both sides, and so it's important for you to be able to distinguish that when the maxillary prominence do not fuse, then you would have your cleft lip, and also then how it even goes as far as causing nasal deformities as it affects the medial nasal the prominence and the lateral nasal prominence, which would be the aspects that form the premaxillar cupid's bone nasal tip. Now, with palatogenesis along the 8th to about the 10th week of intrauterine life, this same interaction between the frontonasal prominence and the maxillary prominence would then form these palates. So we've got, in essence, our primary palatal shelves, which then form from your medial nasal prominence. Remember, we said this would be the premaxilla. So this is the structure that happens in front of the incisive foramen. So these primary palatine shelves will then come together and then form the primary palate, hard palate. And then there would then be the hard palate that forms behind the incisive foramen. This will be from the second palatal shelves. Now, the second palatal shelves, they come from the maxillary prominence. And so what you would then see happening is they initially are located in a vertical position, and they shift from a vertical position facing downward to a horizontal position where they will fuse together. But also remember, this fusion is happening both axially and also in a sagittal plane. So the primary palatine shelves will fuse with this secondary palatal shelves, but also there's the nasal septum that comes from the frontonasal process, which then fuses so as to close and have a complete seal. So what causes the secondary palatal shelves to be able to close? And this generally is due to the tongue moving downward. So we know the mandible generally would retrude, or rather would protrude, and giving space, and then the tongue in itself would then come down. But what causes this tongue to come down? You must always go back to your pharyngeal structures and you look at the pharyngeal arches. And what you would see is that the tongue is actually pulled down by the thyroid gland. Remember, from the foramen cecum, there's that connection with the thyroglossal duct that then forms. So the thyroid forming during that time, pulling down on the thyroglossal duct that has not yet degenerated, pulls the tongue downward. Of course, there's mention of the stylohyoid muscle also involved therein, but this is in essence what will happen. And so you would then have instances where this does not happen, and this then would cause now the tongue, or the mandible rather, to be retruded, and so the tongue, it's now so big that it's unable to fill up the oral cavity because of the small or intrusive mandible, and so the tongue then falls backwards, which we call glossoptosis, and then causes airway obstruction. This is what we call Pierre-Robin sequence. Now you'll understand, I'm not saying Pierre-Robin syndrome because this is a sequence. It follows with, it's characterized by micro or retrognathia, or others would argue retrogenia, plus glossoptosis, plus airway obstruction. That is Pierre-Robin's sequence. And then you may get, in 50% of the patients, a cleft palate that then forms. And this is characterized by a U-shape cleft palate, and that's generally in 80% of the patients. But this is actually protective because you've got this big tongue. you've got the small mandible, or rather you've got a small mandible and a normal sized tongue, but it appears big relative to the space. And so what it wants to do is to fall back. And so in order to accommodate the space, we then have this cleft that forms, so the tongue can be accommodated. So this, in essence, is actually protective because it allows the patient to then feed and be able to breathe properly. So this patients, you would then be able to deduce that we're not going to rush to operate these patients, because once you fix that palate, you are actually endangering the patient. So there's a different way, which we're not going to go into, of how we manage Pierre-Robin sequence. There's, glossopexies that people would do, where we do the tongue lip adhesion, we put them together. But generally, conservative techniques, if you put the child prone, that generally assists. And now we know with distractive osteogenesis that we are able to use that in distracting the mandible. So these kids don't necessarily all have to end up with a tracheostomy, but other procedures such as grommets are things that they may end up with. But just to know, for your level, Pierre-Robin sequence, not syndrome, is generally your microretronathia, glossoptosis, airway obstruction. But the palate in this instance is protective. So we don't want to rush and operate these patients. And I'll leave it there, because there are other many theories that with time, actually, this kind of sorts itself out with the catch-up theory that is there. Okay, now what are the theories of a cleft lip palate? Remember, we spoke about the embryology of how this all happens. So now the theories, as we've explained, one being the fusion theory, that is simply, this is just a failure to fuse, that these structures are not fusing, and so we have a gap, a cleft that then forms. There's another theory then that's called the mesenchymal penetration theory. And what this proposes is that, look, this is not, the structure is not necessarily a trilaminar layer that exists. But in fact, they argue that no, it is actually a bilaminar layer of ectodermal, and this ectoderm actually creates these epidermal walls at the end of these plates that we have. So the plates actually do come together, they fuse, but it's not the fusion that will cause them to absolutely glue together, if I may use such a term. But instead, when they come together and touch, what then happens is that there's mesenchymal penetration that happens, and this is what's going to cause the cells at the walls of these plates to then die off. Apoptosis will happen, and so the epidermal seams cause apoptosis of the walls. And when that happens, the mesenchymal penetration then happens to the opposite plates. And generally, we pick this up when we look at kids. There are also sometimes remnants of apoptosis known as Epstein pearls that we can see along the fusion lines of these clefts. So that's another theory. And then there is one more theory that maybe you may know. Remember, we said the fusion theory. We said fusion then is not enough. The other theory says you need penetration of the mesenchyme. So that's the other theory. And then the other theory says, no, man, this is actually the functional matrix theory. That's what it's called. The neuromeric theory is another name. And it says, no, we actually have chemical tattoos therein, if you may use such a term, that distinguish and indicate when fusion must then happen. But I think if you can grasp that the normal embryology, failure of fusion is a theory, but there is another theory that says, no, fusion is not enough, but you actually need mesenchymal penetration in order to get apoptosis, and then form this glue that ties it together. So that's the main thing. So now that we understand the embryology and we understand the theories therein of a cleft lip and a cleft lip and palate, perhaps we can look at the epidemiology. And just succinctly, it is the most common craniofacial abnormality, and it stands at about 1 to 750 odd. And when you look at them, actually, cleft lip palate is, excuse me, cleft lip and palate is the most common in the cleft, spectrum. So we'd get cleft lip palate, which is 6 times more common. Then you can get a cleft lip only, which is 3 times more common, and then a cleft lip alone. So it's either cleft lip and palate, cleft palate only, and then a cleft lip, and that's the order of the most common to the least common that happen. And generally, when you look at the male to female ratio, more or less, you would get them to be slightly the same, except in the Asian population where we see more males. In the more clefts that are happening, but also when you look at cleft lip palates, you may see more a female predominance on that side. So perhaps a parent may come and ask you, look, and that's the general worry, and that's why we look at epidemiology and say, look, if I've got a child who has a cleft lip palate, what are the chances that my next child will have a cleft lip palate? And generally that would be 4% for cleft lip and palate. But for cleft palate only, it's 2%. And if I've got 2 siblings who have cleft lip, what are the chances? So if there are 2 siblings, there's 9% chance of a cleft lip and palate, and a 1% chance of a cleft palate only. And if there's a parent, only one parent that has cleft lip, then what are the chances? So if there's one parent, then there's a 6% chance of cleft lip and palate for the child being born. And for cleft palate only, there's a 4% chance of that happening. But now, what if you have one parent and you've got one child? A sibling that has cleft lip and palate, what are the chances of getting a child with cleft lip and palate? And of course, that goes much higher, 17% for cleft lip and palate, and 15% for cleft lips only. So it can become very common, just numbers to have at the back of your head. So when parents ask, because that's the main concern, is, okay, I've got this child, but what are the chances of the next one? I think once you've got the embryology right, you've got the epidemiology right, the most important thing would be to classify. What we use to classify cleft lips and palates is the Kenneham's classification. And that looks like a fork, with numbers 1, 2, 3 on the one side, 4, 5, 6 on the other side, and then in the center would be 7, 8, 9. The 1, 2, 3 on the one side representing 1, the lip, 2, the alveolus, 3, the hard palate, and then there's the incisive foramen. And then beneath the incisive foramen, 7, 8 being the hard palate, and then 9, the soft palate. So you just need to look at the diagram of the Kenneham's classification, and I expect that you need to know. Also, I want you to know what is a complete cleft lip palate. It's either complete or it's incomplete. It's either unilateral or it's either bilateral. That's another way to classify. And now for cleft palates, we classify it using the Veal classification, which is VEAU, the Veal classification, and that generally classifies them into 4 parts. Either type 1, where it's the soft palate alone, type 2, where it's the soft and the hard palate, type 3, where it's the soft palate, the hard palate, and the alveolus that's involved. And then type 4, where it's a complete but bilateral cleft. So type 3, type 4, the difference is type 3 is unilateral, soft, hard, plus alveolus. And then the type 4, it's a bilateral of that. So another thing that I would like you to just have a look at is the anatomy. It's important to understand the anatomy. If you can just look at the anatomy of a palate, the normal palate, what it looks like, where the soft palate is, or where rather the primary hard palate in front of the incisive foramen is. Just have an understanding of where the alveolus would lie. Have an understanding also of where the hard palate then behind the incisive foramen then lies, and where the soft palate would then start all the way going to the uvula at the back. What's also particularly important that I would like you to know is also the muscles. At least if you can have an understanding of these two main muscles, which is the tensor palatini and then the levator veli palatini. Their position is important. Their attachment is important because it will define and actually help you to understand what then happens in a patient. I'll give you an example. If you look at the tensor veli palatini, so the tensor palatini is the anterior one, and the levator is behind it. The tensor palatini actually attaches, and its origin is from the temporal bone and the lateral part of the eustachian tube. So what's interesting about it is that it first goes out laterally, then from the origin, then goes around, it wraps itself around the humulus of the pterygoid. So it would go around the humulus and then come and attach on the posterior aspect of the palate. That's particularly important because it goes around and then wraps there within the epineurosis. It needs to go around the humulus in order to be able to tense the palate, and that's why we call it the tensor palatini. The other muscle elevates and pulls the soft palate backwards. So it attaches to the back by the sphenoid bone and the medial part of the eustachian tube. And what it does, it then goes straight and attaches directly to then the palate posteriorly there. And the epidemiology. So what it does, it elevates and it pulls the soft palate backwards. Now this is particularly important because what you must also know is that in cleft palate, the attachment of these muscles are then messed up. They no longer come round and link up and attach to each other. And so the muscles, the position of the muscles in a cleft palate is that they attach on the posterior wall of the hard palate. And this is what causes a notching in the hard palate that we see in submucosal clefts. Remember, there are patients who sometimes you may not know have a cleft palate. They just have this muscle or this tissue that then covers the. So when you look, you don't actually see, and most parents and most individuals don't pick up that this child has a cleft palate because there's this thin membrane that's there. But the way we pick it up is when you look, there's a bifid uvula, there's a zona pellucidum, which is this muscle that is not attached. So that area, we call it the zona pellucidum, that thin layer that you actually see. And then the third characteristic point is the notching of the hard palate. And this notching of the hard palate is actually what is formed by the muscle attachment or the abnormal attachment of muscles in a cleft palate patient. And of course, the zona pellucidum, these kids, we never know, we don't pick it up, but we then pick it up, later, sometimes when they go to school. By about 5 years, the teacher says, no, man, I'm noticing that this child, they don't speak well. And that's when we notice that the speech is hypernasal. That means there's generally a problem, and they will require a soft palate repair, which is just the opposition of muscles, basically, at the age of 5 years. So they will then present late, and we'll touch on it. It's a condition known as velopharyngeal insufficiency that will form. So anatomy, important. Embryology, important. Then once we understand that, we can then go into the manifestations, the clinical manifestations of cleft. So how will a patient present with clefts? Here, and how would you manage? Here's a mother, the child is born. What are the problems that you are to expect? 3, or rather, let's make it 4 that I want you to know. Number 1, difficulty feeding. Of course, you've got a cleft lip, you've got a poor seal. And so, because of that, the lips are unable to oppose, and so it will be difficult for the child to suck from the nipple or from a bottle. Also, they are unable to generate enough negative pressure to then suck adequate milk. So these kids get frustrated, and as you'll see later in life, they will have a failure to thrive. So that's one of the things. And how do we manage that? You can now imagine you've got that. So we would then put an obturator, so that the child does not, the food does not come out of the nose as they suck. But also we would then give them squeezable bottles with a long tip that would then assist. And usually we work with our speech therapist in assisting us in doing this. Another thing, ear infections and hearing loss. Hearing loss, how does that happen? This actually happens due to the increase. Remember, I told you that these muscles attach at the eustachian tube. So the eustachian tube becomes blocked, it collapses. And so you get an increase in internal ear pressure. And this can eventually cause hearing loss. So it's important, and that's why most of these patients, you may need to put in grommets for these patients. Consult an ENT to then assist with this. Ear infections also common. How do they get ear infections? You see, because we've established that we get a blockage of the eustachian tube, secondary to this muscle failure, the levator velipalatini and the tensor palatini. And so what you then get, you have a build up of fluid in the internal ear. And so, of course, when there's a build up and it can't drain the stagnation, then there's an infection that then happens. Further, remember that these patients are also prone to tonsillitis, and this tube is next to the adenoids, and so bacteria can also migrate into the internal ear. So it's important to work in a multidisciplinary team, consult the ENT, and not only that, but also they need to be assessed by audiology, and to have their increase in internal ear pressure assessed by the speech therapist to detect that this is too much, we need to now insert grommets. Speech is a big thing. As you can imagine, why speech is a problem. With cleft lip, of course, there's no opposition, so the child can't say mama or papa, so that's a problem then. Number 2, with the cleft palates, there's this hypernasality. So because there's a gap between the nose and the mouth, the oropharyngeal cavity, and so they then have a hypernasal speech, which makes it difficult. And so also they may then have velopharyngeal insufficiency that generally happens because of this, and we'll go further later on to discuss this. And so it is important. You will find that these kids, they're actually clever. They would start to either replace, to omit certain words, or to make up other words, or avoid pronouncing certain words. And usually it's the vowels, that are affected with VPI. And so for these, it's important to make sure that by the age of 12 months, a year, you must have repaired this, because the brain cognitive learning of speech is already formed and may be affected, forever. Perhaps since this talk it may also be directed to registrars, what are important not for you students but the registrars perhaps to know, our residents, regarding this is also how to diagnose it when you look at the patient nasally. Just know what are the nasal deformities in a cleft lip patient. It's important just to know, and to know the principles of correcting it. Just to run through, it's easier for you to just break it down to bone, cartilage, and soft tissue. Bone, what's the problem? The maxilla, of course, either retruded or the hyperplasia, where on the cleft side, the piriform rim usually is retropositioned on the cleft side, and the inferior turbinates actually may be hypertrophy, on the cleft side. With regards to the cartilage, the nasal septum itself, remember there's the cartilaginous septum, and there's the mucosal septum rather. So what you would get at the caudal septum, you will get deviation to the non-cleft side. And on the posterior septum, so the membranous septum, right there, there's deviation to the non-cleft side. And on the posterior septum, there will be convex, or rather it would be convex on the cleft side, and this can further block the cleft side airway. Also, just to know about the lower lateral cartilages, they are generally attenuated and displaced caudally on the cleft side. The medial crus would be retro-displaced most of the time. The medial crura also, they are separated from one another at the dome, and the alar dome is generally depressed. And if you look, the angle between the medial and the lateral crura would generally be more obtuse on the cleft side, and there you would see buckling in the lateral crura. And just soft tissue, just to know that on the tip is usually deviated to the non-cleft side. The columella, the base is deviated also to the non-cleft side, but it's shorter on the cleft side. We spoke about the alar rim. The alar rim on the cleft side, alar base, it will be displaced laterally, posteriorly, and caudally, and there would be diminished alar groove there. And this would generally also affect the nasal aperture, or rather the nostrils, where it would be wide, and the nostril seal would be deficient on the cleft side and horizontally rotated, and you may have vestibular webs. So these are just some of the things just to have a look at, and how we would then fix it with the Tajima sutures or the Macomb sutures, how we can do transdermal suspensions, when we do our cleft palates. So that was just on the side of residents, so that they may know. Now, let's get back. How am I going to manage a child with clefts? By the way, there are syndromes that you must just know about. We spoke about the Pierre-Robin sequence. And so the syndromes that are generally common, maybe three, just to know: the Stickler syndrome, which is the most common in cleft palates patients. It's about 17 to 24%. And in essence, this is, kids with Pierre-Robin sequence, as we mentioned, and plus they would have ocular abnormalities, hearing loss, and arthropathies. That's what distinguishes these features. And then there's the Van der Vonde syndrome, which is the most frequent case for the cleft lips and palates. You'd find that 2% of the patients actually have under Voda syndrome, which is cleft lip and palates in about 2/3, or cleft palates only in a third. And what's characteristic is they have these bilateral lower lip pits, and they would have these hypodontia, which is one or more teeth that would then be missing. Another one, maybe just know about Treacher-Collins syndrome, and maybe blepharochilodontic syndrome, maybe one that you must know about. But generally, Strickler, Van der Voorde, Treacher-Collins, I would be generally happy if we know about those. Now, how are we going to manage the patient? The way we're going to manage this patient, there are either surgical and non-surgical. So the main thing, I want you to be step orientated. So imagine yourself looking at a mother and advising them from the start when they have this patient. So the non-surgical ways of managing, first is feeding. You've got to address feeding. We spoke about the squeezable bottle. We must advocate that the child is usually nursed in a prone or semi-prone position, and this is to actually prevent regurgitations during feeding. Obturator is what we may also put there to assist us. Then we must also involve the geneticists, because remember I told you about syndromes just now. So we want to exclude syndromes or chromosomal issues that may require preempting and management on an early on stage. Then speech, we spoke about it, so you would refer speech for issues of speech and hearing. We'll deal with that. So we want our ear assessment audiologies, and would involve our speech therapist, our ENT surgeons, and generally would monitor then these patients. But let's not forget the psychological aspects. We must get a psychologist involved in this, because the family needs support. They're going under tremendous strain. They don't understand what's happening. This may be the first child, so we really require family support. Orthodontist is one that we definitely need, and we've seen that orthodontist is imperative in the collective management of cleft lips and palates. Generally would need them early on in nasal-alveolar molding. And what's nasal-alveolar molding? It's in essence, we can either put in either passive or active devices. The active, which can be adjustable. And generally, we want this before about 3 months of age. And we found them to be quite useful in assisting us to actually get the alveolar or this premaxilla aligned, and we can be able, if we can get the alveolar and the gingiva to align, then we'll be able to then do a proper repair. And they generally have two arms. The alveolar, or rather maxillary arm, which would go in almost like, call it the obturator, and they would be fixed therein, and they would distract the alveolar ridge so that the space can be made for the premaxilla to fit. So we are pushing, you can imagine in a bilateral cleft, we are pushing this alveolars. We've got this thing in between, on top, on the palate side, pushing the alveolar on the right and the left apart, so that there can be enough space for the premaxilla to fit in. We also have the nasal arm that's there to prevent this nasal widening. We have some problems with it, in kids, doesn't work so well, keeps coming off as the kids, they're less cooperative, there's nasal secretions, but this is nasal alveolar molding that we must just know about. It's assisted us, because what's the aim? We want to get alignment so that we can be able to do what we call our gingival periostoplasty, which is the GPP. And what is that? We just want to now then open the sleeves together and put the gingiva periosteum then together. And this then says we need maxillofacial surgeons as well to be able to assist us, so that they can then assist us in the gingival periostoplasty. And generally for that, it can either be done at the time of the cleft repair, but we generally do it later on, because what we generally want is the gap to be at least 1 millimeter, and the apposition or the displacement of these alveolar ridges must be less than 2 millimeters in order to allow for the GEPP, the gingival periostoplasty, to be formed. And of course, the orthodontist still would help us later because they would be involved in orthodontic surgery. What is orthodontic? Ortho, from the Greek word, ortho means to straighten. Netic is the mandible, so we want to straighten the teeth or the mandible, and that's what orthodontic surgery is. It's about the bite. We want to be able to get a good bite and not have malocclusions. Incidentally, just for perhaps the residents, it's important to know your different types of malocclusions, your type 1, type 2, type 3 malocclusion, and exactly what is involved therein. I won't go into that there. Let's quickly just go into the surgical part and then we wrap up. What is the surgical options that we have? First, we start with the timing. Timing for cleft lip needs to be between 3 to 6 months. Millard raised a principle. I think it's the Millard criteria, the rule of tens, where the patient must weigh 10 pounds. That's about 4.5 kilograms for us, 10 pounds, 10 weeks old, and the hemoglobin must be 10 grams per deciliter in order to do it. Incidentally, others have added less than 10,000 of leukocytes or white cell count also required to assist in that. So generally, 3 to 6 months is our time of repair for the cleft lip. Cleft palate, 9 to 12 months. And remember, I've mentioned that's where we'll do either we can do our gingival periostoplasty, plus secondary bone grafts. And these generally we do them 7 to 10 years of age. And we're looking at, basically we want to do it before the permanent canines form, because that's the whole point of aligning it. So 3 to 6 months cleft lip, 9 to 12 months cleft palate, and then the gingival periostoplasty and secondary bone grafts. We're looking at 7 to 10 years. There are secondary procedures that are also done at about 17 years of age, and generally this would be your rhinoplasties, if you do your secondary rhinoplasties, or also the orthodontics would then continue into that. So those are your main repairs. And just to know the options, which I'm not going to go into detail, options for cleft lip, if it's unilateral, we used to speak about lip adhesion at about 1 to 2 months of age. And that would assist, basically, it was an early conversion of complete to an incomplete cleft. But instead of taping as an alternative. But now that we have nasoalveolar molding and taping, they do assist. And lip adhesion is not necessarily always done. But the procedures you may know about, maybe for unilateral, we've got our Millard rotational advancement flap, and multiple modifications from the Millard rotations that then come. We've got our Rose-Thompson, which is the straight line repair. There's the triangular line repair. There's then additions where there's not of triangular flaps that you can add to address the vermilion height discrepancy. But generally, most done is your either Millard rotational advancements, a few modifications there, and a straight line repair. Those are usually the procedures that are done. And for bilateral, I think we've accepted most of us. Of course, there's the Milat, but the Mulliken repair generally is what we use in our setting for bilateral cleft lip repair. Complications, I think just to maybe know the complications you may get after fixing the lip, you may end up with muscle secondary deformities, and these are usually patients who have this discontinuity that's present, generally in a unilateral cleft lip, where you have this groove there because the muscle is not together, and then you would find ways to fix it. Basically, you just recreate the cleft. That's what we do, and we appropriate and you put it in an appropriate position. There can be a deformity, not just of muscle, but of the vermilion. So you may have vermilion irregularities. Generally, the deformity, we call it the whistle notch deformity. And you must just have a look at it where you have minor defects, moderate, and severe whistle notch deformity. And basically it's inadequate approximation of the marginal components of the orbicularis oris muscle within the rate line. And generally there's many ways to fix it. You can either rip open the inferior incision and then symmetric evasion, and just align everything, or you can use Z-plasties in the wet vermilion, or if it's quite severe, there's cases where people have used AB flaps to try to fix that. You can have a short upper lip where you've got inadequate lengthening at the primary repair. And so you must just evaluate these patients quite carefully to determine if it's actually vertical deficiency that's the problem. And muscular mucosal is not, there, or it's all of them that's involved, because it will involve the way you fix it. And generally, we recreate our defects and repeat our rotational advancement because we use them a lot. And then you may also have a long upper lip. Generally, that's found in, your bilaterals. And it's usually secondary to failure of basically to resuspend the nasal muscle sling and oral sphincter up to the anterior nasal spine. And you would fix it. Generally, for these, we need to open up the entire lip and align the primary lip repair properly. And so you may also get a tight upper lip, and we generally find ourselves using AB flaps for this. But just to know, these are some of the complications, more for residents, not for you students, and how we can then fix this. Also about the nose, the rhinoplasty, how we can correct primary corrections or reshaping of the nasal alar for the primary and secondary repair. Just to know something about how you can, lengthen the columella for the registrars using different flaps, whether the simple VY advancement flap, the anterior pedicle rectangular flap, the forked flap as described by Millard. There's the Brewer Forrester technique, and yeah, you will just need to go through that and be able to describe that. But this is not for the students. I think that should be enough. I'm happy if we know about that, and how to then fix that. And maybe for cleft lip palates, just procedures to know. For the soft palate, there's the interveloveloplasty, there's the fallow double opposition Z-plasties that you can then use. It is quite difficult and challenging, I must say, with our experience. It's easy and nicely described in a textbook, but you are working in a small area, and you're also unable to do this in a wide cleft, as you must pull these flaps, which are quite thin. But interveloveloplasty, fellow double Z opposing Z plasties, that's another thing you can use. And for the hard palates, I'll mention three: the von Langenberg procedures. There's the Badach two-flap palatoplasty, and there's the Vio Woodall Kilner, the VY pushback palatoplasty. So I think for the residents generally, you need to know quite detailed about these procedures and what we actually do. Which one do we use in bilateral? Which one is better in unilateral? But students just know, for cleft palate, for the soft palate and the hard palate, there are certain procedures to use, and you don't need to know the technicalities therein. In this lecture, I won't go into the VPD, which is your velopharyngeal insufficiency there. Well, the insufficiency is a problem with the anatomy, and then there can be problems with the neurology, but also there can be mislearning that happens. But generally, there's different types of defects that you would get, and you would need to learn certain repairs for these type of defects, whether they are sagittal, coronal, and have a look. But we'll discuss VPD in a separate lecture. I think I'm happy as long as now for clefts, I know it's a big topic. It's quite intimidating if you don't know the concepts, but if you can catch it early, all you need to know is the embryology. Know that and know it well. Know the anatomy, epidemiology here and then. Know how to classify, and then know the clinical manifestations, the feeding, the hearing, the infections, the speech. Those are the big things. And know how to treat a patient from feeding. Know who to involve, the geneticist, the audiologist, the ENT, the psychologist, orthodontist, max fax. And generally the timing is important of the lip, as we've mentioned, 3 to 6 months, cleft 9 to 12 months, and then the other procedures, changeable periotoplasty and secondary bone grafts. It's about 7 to 10 years of age before the permanent canine forms, and the secondary procedures that are then there. And just know about the options, that for the cleft lip, these are our options for unilateral. These are my options for bilateral. And for cleft palate, these are my options for the soft palate, and these are my options for the large palate. I thank you for your attention, and we'll meet next time. Thank you. Bye.